I got into the research world in a very cursory fashion. I'm not a I don't often participate in chiropractic research, but I have in the past. Years ago, the president and founder of Life, Dr. Sid Williams, offered the faculty the opportunity to do research, and in return, we got some time off from teaching in the classroom. So I jumped at that opportunity because, for whatever reason, I was looking for a change of pace. And at the time, the research department had a setup illustrated in that picture on this slide of a goniometer that measured all three ranges of motion of the spine using ultrasound. And it's hooked up to a computer. The patient actually wears emitters, ultrasound emitters on their body. And the sensor, this device right here, picks up those emissions from the sensors that are placed at strategic areas of the spine to be able to measure flexion and extension, lateral flexion to both sides, and rotation in all areas of the spine. And that sensor sends that information to the computer, which then gives you an actual angle measurement. So it's very, very accurate. It was designed for athletic measurements to enable athletes to have better range of motion. It was a Zebras, made by Zebras, ultrasound detector. And so I decided to use it in my research project to see if Category 2 SOT blocking had any effect on ranges of motion of the spine. And I did a case series. I measured 5 people, pre and post Category 2 blocking. And the conclusion was supine pelvic blocking, as is used in SOT Category 2, affected lumbar ranges of motion in these 5 cases, mainly lumbar. It had an effect on the cervicals, but it was much more subtle. And I would expect that, it's reasonable to assume a pelvic adjustment would have an effect on lumbar mechanics. And we actually measured that. So I submitted my project to JMPT, and after a very frustrating year, they accepted, after several changes to the paper, they accepted it for publication. And it came out in 2005. I then had an interesting case of a patient who came in with itching all over her body. She was a nurse, and she worked in a hospital, and she had been misdiagnosed as having dermatitis. Well, that's a silly name, really. It means your skin itches, inflammation of something in the skin, or eczema. And she didn't think she had eczema, and she didn't seem to have eczema, although I'm not a dermatologist. So I checked her out chiropractically, and I was led to a chronic T9. And T9 is the adrenal glands. So I adjusted T9, and then I gave her a supplement to support her adrenals. I believe I gave her Drenamin by standard process. And I did, in addition to the T9 adjustment, I did some reflex braking between the adrenals and the spine, known as chiropractic manipulative reflex technique, one of the 5 stars of SOT. As a result, after years of itching, within 2 or 3 visits, she had no more itching, and I was as amazed as she was. And that was presented at ACC RAC in 2009 and published in the Journal of Chiropractic Education. I had a fascinating and one of the most rewarding cases back in probably 2010, when a patient came in with chronic migraines. He was a graduate from Life University in the nutrition department, and he was a semi-pro hockey player. He had migraines every day, and they were really ruining his life. and they were ruining his wife's life. And they basically told me that I was the last person in a long line of people that they had seen. And I listened to his story, and he mentioned that someone had told him that he must have a subluxation of the sphenoid bone. And of course, when I heard sphenoid, I thought coccyx, because people don't injure their sphenoid without fracturing their skull in most cases. I mean, you can screw up the sphenoid with a concussion, and he was a hockey player. And people had worked on his skull and his neck, several chiropractors, with no change. He had also had 5 or 6 surgical procedures performed, exploratory surgical procedures, including a transesophageal EKG, which I had never heard of, to see if there was something wrong with his heart. To make a long story short, I checked his coccyx, and it was severely subluxated. And I figured, well, maybe the subluxation of the coccyx is causing the sphenoid to react in such a way that it's creating the symptoms that he is interpreting as migraine pain. So, to make a long story short, I adjusted his coccyx, and I didn't do it in the way that is illustrated in this picture. I did it externally, placing my thumb along the posterior inferior aspect of the tip of the coccyx, and with a drop table thrusting very strongly I to S. Within about 5 or 6 visits, his migraine started to break for the first time in 7 years. And when he told me that, it was one of those times when chiropractic blew my mind. I was so happy for him. And he eventually moved away, went out to Colorado. I referred him to a well-known applied kinesiologist because I couldn't find anybody who did SOT and analyzed exactly the way that I did. But that was an amazing, amazing case, and I presented that at ACC RAC in 2011. I assisted as the treating chiropractor in this study, done mainly by Dan Tuttle, a relatively recent life graduate. It was accepted to ACC RAC in 2015. Dan is a DC now, but he has a master's degree in clinical social work. He's a counselor, clinical counseling, and he uses a form of biofeedback called quantitative EEG to see the condition of the patient's brain pre and post counseling and behavioral changes. He was, of course, assisted in this, in writing it up, by Stephanie Sullivan, our DC PhD. She has a PhD in a branch of neuroscience that deals with how we know what we know, and processing, especially cortical processing. And Ron Hosick, our DC PhD, Ron has a doctorate in biomedical engineering, and he was one of my teachers when I was in chiropractic college. Ron helped design the setup for Dan to do his work, and also being a statistician, he ran the statistics for this. And Dr. Sullivan used the outcomes of that study to get her PhD. That was part of her PhD dissertation. She is currently involved in using the data that Dan collected to get published. And Dan is in practice down in Florida. And when I watch Dan adjust patients, I feel like I'm watching myself. He works more similar to me than any student I have ever had. He started out as a patient of mine. Dan's wife has a PhD in molecular biology, and so the two of them are two brainiacs, and Dan is very much into SOT. He's always at the SOT seminars. And what I did was, this was changes in brain activity after the adjustment. I applied either the real adjustment in the form of category 2 blocking or a sham adjustment in the form of, I believe, a T11 activator adjustment with the activator set at 0. And Dan showed pretty conclusively that the correct adjustment, in this case category 2 SOT blocking, really does change brain activity and seems to be making the brain much more efficient. The first study that had anything to do with SOT that was published in a peer-reviewed journal was back in 1993 in JMPT, and this was TMJ associated with sacroiliac sprain, done by Tom Gregory, postdoctoral student, University of Maryland Medical School, who I believe is now also a chiropractor. And he states that external derangement type TMJ disorders were temporarily relieved following SOT treatment, including category 2 blocking, to reduce sacroiliac sprain. There seems to be a cause and effect between what's called external derangement type temporomandibular dysfunction and SI sprain. And so he's promoting the co-treatment of TMJ issues, not only with dental appliances, but also with chiropractic. A review of intra-examiner and inter-examiner reliability of static spinal palpation. This shows that just statically palpating the spine doesn't have a high level of inter-examiner reliability, which means that if you do it and I do it and somebody else does it, the likelihood of us agreeing on what we're finding is low. Palpatory pain, however, was more reliable. However, there was no method of palpation that showed itself to be any better than any other method. So palpatory pain is okay. It's actually very good as an indicator of dysfunction. But how evidently not all the schools are teaching palpation the same way. And I know that all chiropractors don't palpate the same way, and you do too, because you've been palpated by a lot of people by now, and you know they don't all feel the same. This is about the R plus C factors. That's the DeJarnette nomenclature for the Lovett brother idea, that C1 and L5 are related to each other and they seem to react to each other. C2 and L4, C3 and L3, sacrum and occiput, temporal bone and ilium, and sphenoid and coccyx. So what they did is they had an experimental group of 26 people and a control group of 12 people in the patient base of one office, and the office is run by Dr. Charles Blum, a very active researcher in SOT especially. And these people were selected from his office, and these people had sensitivity at specific cervical reflex points. These are the points that we use in category 3, which we'll get to give us the lumbar listing. So he used a pre and post outcome measurement device and the protocols taught in category 3 to adjust the lumbar or not adjust the lumbar. And how he adjusted the lumbar is determined by what he found in the neck. So he found that there was a statistically significant difference between pre and post measurements as far as how was the pain in the cervical spine after the lumbar adjustment. You would expect that if you adjust the lumbar, the palpatory pain in the cervicals that actually gave him the lumbar listing would decrease or at least change. And so he did see that the findings suggest that further research is warranted, and that there was a statistically different outcome in palpatory pain in the cervicals on those patients who had been adjusted versus those who hadn't. You wouldn't expect that cervical pain would change if he never adjusted the lumbar spine. And this is a study about the piriformis. And the reason I included this in this batch of research studies was because the piriformis is checked in category 3 patients. Piriformis is often a diagnosis of exclusion. In other words, okay, it's not a disc, it's not a lumbar problem, it's not the SI joint. It could often be piriformis irritating the sciatic nerve. It's the muscle most closely associated with sciatica. And this was a patient with piriformis, unusual piriformis. It just didn't grow right. He had accessory superior bundles of right piriformis musculature, and those muscles were cut in surgery and afterwards. Well, was it cut in surgery? Let's see. No, he had a lumbar and spinal manipulation at the sacrum, soft tissue massage. Variations from routine care included proprioceptive neuromuscular facilitation, muscle stim, acupressure, and point stimulation. SOT was used, and a bunch of other stuff, and it helped. So even though he had unusual anatomy, he didn't always have sciatica. So surgery, this is a good indicator that surgery is not necessarily warranted. And this is a study that was done in the Journal of Chiropractic Medicine 2003 that shows a commonly used category 3 procedure called the sitting disc technique. And we're going to get to that. And so this will be available, and where you use the block or your thumbs to pry the spinous process of the lumbar above the bad disc in an I to S direction to reduce disc pressure. This is the role of chiropractic in treating asthma. Again, another Charles Blum study taken from his office. There's actually a lot of studies on chiropractic and asthma. We seem to have a very good effect on that. I just found out yesterday that a patient I saw last week, who's a bedwetter at the age of 8, after his first adjustment, his mother said he is 10 times better than he was. And in that child, I did have to adjust his sacrum, and he had a rather unusual T12 subluxation, which I adjusted. T12 happens to relate directly to kidney control. So I'm glad I thought of that when she was telling me that he seems to have no control over his bladder. He would pee during the day. He just didn't, he couldn't tell when he was going to release urine, and it was becoming a major issue, I mean, at the age of 8. So that seems to have controlled it, so I'll be seeing them again. This is a great study that illustrates how chiropractors and dentists can work together with patients who have jaw and TMJ dysfunction. And this was written by Al Chinapi, who's a dentist, and Harvey Getzoff, who's a chiropractor. As a matter of fact, Harvey Getzoff wrote the previous study that we just looked at on the sitting disc. I've known Harvey for many years. I'm not sure he's still in practice. I hope he is. He's an excellent SOT practitioner up in Cherry Hill, New Jersey. And this was a 33-year-old woman who had a bad overbite, severe crowding of the lower teeth, a lot of headaches, jaw popping. So she got adjusted by SOT and also treated by the orthodontist.